Hello, everybody. This is Mike Taylor and Adam Roseman at Greenberg Charig. I'm the chair of the Greenberg Charig OSHA practice group, and I'm based out of our Washington, D.C. and our Northern Virginia offices. My colleague Adam is based out of our Philadelphia office, and he's also a member of our OSHA practice group. To learn more about me, Adam, and or our practice group, go to www.gtlaw.com. and you will find our information there. Today our special guest is Mr. Mark Catlin of MDC Consulting and Training in Columbia, Maryland. Mark has 40 years of experience in industrial hygiene, providing technical, policy, and training assistance on occupational and environmental health and safety issues for labor unions, employers, universities, and federal and state agencies in the healthcare, service, construction, manufacturing, and environmental sectors. Welcome, Mark.
Thanks, Mike. Thanks for the invitation.
Hey, we're so excited that you're here with us today. Going through some of your background, one thing I did notice that you had the experience with, which I'm interested in, I know probably a lot of our listeners will be, is your work regarding the 1989 Exxon Valdez oil spill cleanup. You were part of that cleanup, is that right?
I was, but not in the way most people think about involvement in that sort of event. I was actually assisting the laborers union, which is one of the largest construction unions in Alaska, and I'd been assisting them on health and safety and training issues for a couple years before this spill occurred. And when the spill occurred, a large number of the cleanup workers were their members, and so that's how I got pulled into health and safety issues on the oil spill cleanup because of that.
That's very interesting. Were you dealing with a lot of HAZWOPER type issues? Is that what was going on?
Yeah, work had started a couple years before, and I moved to Alaska, assisting them with asbestos training issues because there was a lot of work. And then the laborers union saw both the potential for work in the HAZWOPER remediation area in Alaska, and also the value of this HAZWOPER training, which is very broad. And if you think back to those days, most workers had very little training. HAZCOM had just come into effect recently, so and we actually did not a 40-hour HAZCOM, we did an 80-hour HAZWOPER class. And so we had a lot of time for both in-class and hands-on practice. And so we started training shortly after the standard went into effect in the first standard in 87. And so we had been doing training about a year and a half when the oil spill hit. And a number of the early cleanup workers who went out to the site in the Prince William Sound had been through this HAZWOPER training. So they had good backgrounds and were prepared to ask questions and report back what they saw.
Do you have any interesting stories to tell about the spill? How long was it, or was the union involved in making sure that workers were safe in the cleanup?
Yeah. Well, it's really interesting in a number of areas. So first of all, it's the Exxon Valdez oil spill cleanup in Alaska that started in middle of March of 1989, and the major cleanup took place over about the next 6 months. It then was suspended for the winter because it was too dangerous to work in those waters in the winter, and then it was restarted the next year to finish up what they were going to do. That was actually the first time that an OSHA agency, in this case Alaska OSHA State Plan, went into voluntary compliance mode, as far as I can tell. And so they were so overwhelmed with the size of the spill and the thousands and thousands of people involved and the incredible geographic distance, that the state OSHA program went into voluntary compliance, and that had as far as I know, that had never happened before. And now it's become pretty routine with OSHA during emergencies and disasters to go into the voluntary compliance mode. Okay. And then beyond that, the other kind of issues that really happened in that oil spill was we had recently had, as I said, the HAZCOM standard had come into effect. HAZWOPER had just, the final standard had just gone into effect a few months before, and was determined that it applied to oil spills and oil releases. And then the updated benzene standard had just gone into effect a year or so before. And so those are all issues that impacted health and safety, especially health issues around an oil spill cleanup, which had been, oil spill cleanups had been happening for a long time, ever since OSHA began and before. But this was kind of there were a lot of things all came together at that point to suddenly sort of focus attention on safety and health. And I think the training of the early cleanup workers from the laborers union that we had done, had heightened their both understanding of health and safety issues and asking questions, and then they knew they could call back to their union, and they had a way to do something with whatever they thought were problems. They could get help.
I want to just go back to something you said, because maybe our listeners may not fully understand. When you said it was the first time that Alaska OSHA went into voluntary compliance mode, can you help us understand what that means, especially as it relates to, a big sort of disaster like this, right? This isn't your run-of-the-mill OSHA enforcement issue.
Right. Well, because of the enormity of the scope, and because because of the sort of legal and paperwork and administrative issues of issuing citations, the decision was made to just go out and try to do voluntary compliance and help contractors. There were the state at that point probably had less than 20 inspectors for the entire state, much less adding in for the spill. And so OSHA has, federal OSHA has sort of picked that up. The World Trade Center, they were in voluntary compliance, cleanup after Hurricane Katrina and many of the other sort of disasters. And that's sort of become almost common at federal OSHA and many state plans, as early on they go into just trying to help with compliance and not issuing citations.
Hey, Mark, if you don't mind, I'd like to bring you down to maybe the lower 48 states for the moment and ask you, we're sort of tracking your career here, right? I want to ask you a little bit about something we saw that you sort of helped lead a successful campaign with Cal OSHA to create its aerosol transmission disease standard. And we don't need to obviously explain why that's an important standard these days, given we're all doing this virtually in a pandemic. But sort of talk to us what your role was in that campaign, what the union's role was, and what that standard is, right? Because obviously federal OSHA doesn't have that exact standard.
Right, and that standard may become, it may be the model for what OSHA might come out with an ETS for healthcare or whatever, but that actually is a standard that came out of an industry request of the hospital industry to Cal OSHA. And the way that I was at the time on the health and safety staff of the Service Employees International Union, and we represented over 500,000 members in California in healthcare, public sector, and some other types of work sites. So we got a call from one of our union reps in California. He had been invited to a meeting with Cal OSHA, where they were doing their initial stakeholder meeting to see if the industry request could lead to a new standard. And what the industry had wanted then, and it's sort of a complicated history, but the industry had gotten a reprieve from doing respirator fit testing under OSHA's 1998 updated respirator standard, because OSHA was working on a TB standard. OSHA in the early 2000s abandoned that TB standard, which meant that the hospital industry now had to comply with the respirator standard, including doing fit testing. And the hospitals in California, who had some experience with Cal OSHA on bloodborne pathogen and needle stick safety and some other issues, went to the state and said, could we get relief from annual fit testing? It's really hard for us in healthcare. And the state regulators, to their credit, didn't say like, no, we can't do that. What they said is, we could do it, but it had to be as part of a comprehensive standard where we could make sure that protections were there. And so we got a call about whether SEIU as a union wanted to participate as stakeholders and help work on the development of that. I have to say, our initial response was skeptical, because at that time there was a federal rider on federal OSHA's budget that OSHA around the issue of fit testing and tuberculosis, and we had been fighting hard to get rid of the rider, and we weren't sure we wanted to be involved in something that would give industry a break on fit testing. So it's sort of a political issue for us. But we decided it was worth the potential positive benefit was worth at least being in stakeholder meetings, which lasted for several years before the standard was passed in May of 2009.
Interesting.
So it's actually an industry endorsed the standard, or the industry asked for the standard. They were partners in the whole stakeholder process. And then everybody at the standards board meeting in May 21st, 2009, everybody, labor, management, professionals, everybody voted for the standard, which was really quite amazing. Not only that, but the Cal OSHA staff who wrote the standard got a standing ovation from everyone in the room because they had done such an outstanding job of outreach and negotiation. Now, that was also at the beginning of H1N1 when no one knew how bad that pandemic was going to get. So I think in some ways we got lucky.
Yeah, speaking of H1N1, this is somewhat near and dear to my heart because my daughter got it and was in the hospital and almost died. She was in the hospital for 30 days and lost a third of her body weight and had to learn how to walk again. And I'll never forget, the lung doctor looked at me and he said, "Mike, 15 years ago, I wouldn't have thought to have put a chest tube in a 3-year-old because she'd gotten bacterial pneumonia, which was what was happening at the time with H1N1. My understanding is that it was compromising people's immune systems so bad that they were catching really nasty diseases along with it." And he explained to me that his theory was that general practitioners were overprescribing antibiotics. So I know, the H1N1 is always at the back of my mind. Kind of interesting story to tell that my daughter is a major swimmer now. So
good, great.
Yeah,
good.
So she came out of it, and it's now she swims competitively all over the U.S. So it's kind of interesting. With H1N1, I know that you're involved providing occupational health, technical, and policy support to the Service Employees International Union associated with the pandemic. Is that right?
Well, I worked for them almost 15 years and did that, in lots of issues, but certainly during the H1N1 pandemic and then Ebola after that. Yeah.
Right. So what did we learn about H1N1, and how did we drop the ball and not be prepared, to be blunt, with the coronavirus?
Yeah, I've thought about that often after this pandemic began, because we had learned lessons in terms of occupational safety and health from H1N1, the experience in California with the ATD standard, and then the experience was with the initial SARS virus in Ontario and other parts of the world where healthcare issues and the healthcare exposures were an issue. Yeah, I think what happened as I think back is I know in California they were after H1N1 they were suffering enormous budgetary problems, and I remember the staff of Cal OSHA who helped write the ATD standard. There was a hope that there would be like a debriefing and lessons learned and then follow-up training, education, and it turned out they were furloughed often, and so there was just no time for that staff to do that. By the time that got resolved and they came back to work, then Ebola hit a couple of years later, and then that took up the attention. And so I think we've had these missed opportunities. Some of the issues that that we're seeing now that are that were highlighted back then were the issues of how are these respiratory viruses spread? Or the California standard takes this aerosol approach, which sort of combines airborne and droplet spread from the traditional paradigm of infection control. And that may not seem like a big deal, except that in terms of occupational health, it's a huge deal of whether it's droplet spread or airborne spread, right? Because now you're talking about ventilation and respirators and all that. So in terms of our work, it's a huge difference of where you start from, or and sort of what you do based on where you think transmission is occurring. And I think it's been a tough transition, I think, in the healthcare sector and the infection control sector to sort of adapt to, I think, is the future paradigm, which is the growing evidence we're seeing around this pandemic, but other exposures of this of not a dichotomy of airborne or droplet, but really it's probably it's a gray area where there's small and large droplets that can be where people can be exposed to both routes, and so we have to deal with both routes. And that just that's all. I think it was a lesson that wasn't learned 10 years ago in H1N1, and we're still kind of working our way through it now.
Yeah. Well, hopefully we figure out and the lessons that we're learning from COVID and apply them going forward for worker safety and just human health.
Yeah. One of the things that really strikes me from this pandemic compared to H1N1 is is the asymptomatic spread. And that was something I don't recall in all our stakeholder meetings and discussions, which were extensive. Did we ever talk about an illness that would be asymptomatically spread? And that's, again, that has made this
Right.
that much
Yeah.
harder. Yeah. And we did talk about in the development of the center, there was discussion about what if there is a major pandemic. But, there was a lot of pandemic flu planning back then. And it was really, I think, hard to really wrap your head around what that would going to mean. And, it'd be easier now because we've all lived through it. But back then it was hard to imagine how tough this could really be to deal with.
Hey, Mark, is there anything, because we saw you're doing some work with the National Education Association, the NEA, helping them. I, again, don't know what the scope of the relationship is, but can you talk to us, gosh, I mean, if you have school-age children, this is always top of mind, right? Getting kids back to school. But just what's the sort of scope of your engagement? And have you learned any lessons that you've taken from the sort of H1N1, stuff that you did, or even Ebola, although that's a little different, that you've sort of tried to put into practice, with this pandemic and the consulting you're doing there?
Yeah, and it's and that's been real interesting work in school settings because I hadn't done much work in school settings. A lot of my work had been in the healthcare setting. So, but and I think that's another difference with H1N1. The biggest focus, we didn't have this such a large focus of everybody. There was more focus, which also makes it hard. So it's interesting trying to think about doing occupational health and infection control with work sites where there's not that experience. Healthcare work sites, you can have these debates and talk about some of these control issues, and it's with staff and management that have some experience. But in a school setting, there's some history of indoor air pollution in the past, and certainly asbestos issues, but not this infectious disease issue. So I think a big part of it is trying to sort of connect up the transmission issues with the controls. So, for example, what I often hear in talking with employers at school districts is, well, it's sort of like, well, we're concerned about airborne exposure, and they'll talk about what they might be doing for ventilation or what they can't do for ventilation because the system doesn't work. And they'll say, but we're doing extra cleaning, and say, well, but that sort of misses that you can't substitute one control for one transmission for another. But that's really difficult it's just difficult to get across to people, I think, because
Right.
it's not how people are used to thinking. And I think that's a big part of this outside of healthcare is the real lack of experience in thinking about infection control that is not easy. This is incredibly complex, difficult stuff. You see lots of folks who want to do temperature screening and symptom screening, which is not a bad idea, except with asymptomatic spread, then you can't guarantee that you're keeping out people that might have illness. And so that it just makes all this that much harder.
Yeah. No, that's interesting. And gosh, I have to imagine you've been a busy man through all this, especially with your wealth of experience in this. So, Mike, if you don't mind, I do want to ask one question, more of a wonkier question, which is, you've been involved in a lot of union negotiations, I assume. Is there something, do you sort of sit here and say, there's a suite of safety and health related things that are sort of must-haves in union negotiations, and how do you sort of go about trying to get those, right?
So I've been union staff. I'm not an elected official. I'm not the final decision maker. I'm the staff providing the technical advice. If I'm an elected union official at local level, state, federal level, I actually have a number of legal responsibilities to represent my members, and safety and health is actually one of those under the requirements. But I also have those union reps also have rights on both under OSHA standard and under labor law, depending on how they're covered. So as a health and safety technical person, my role is to try to help those labor leaders understand what tools are available and how to use those, and give them the advice and encourage them to hopefully do what they think will fit best in that work setting. So it's hard to come up with one absolute, because so much of the bargaining is site specific, company specific. But for example, things like rights to information. I mean, we would always want to get that into collective bargaining agreements, even though it's under the OSHA rules. workers and unions have rights to, the OSHA 300 logs and lots of other information. But to put it in a collective bargaining agreement makes it a lot easier to access it, or requirements where it's automatically provided like quarterly so that the union gets it. And then the other one is the role of union labor management mechanisms to deal with issues and problems like safety and health committees, joint committees, or just other labor management committees where safety and health is recognized as a part of that. And that's a place where these issues can be raised and fought over and solved.
That makes sense.
How do you get access to the site? Is that something that's put, let's say, I don't know, workers start complaining about an airborne contaminant in the workplace. Is there typically something in the collective bargaining agreement that allows you, so to speak, to access the work site to see what's really going on?
Yeah, and so there a lot of contract language has different types of language that says union reps have right of access to represent members and to investigate problems, and that could be how I might be brought out. Often it's done pretty informally, where the union has some relationship with their employer, and they just say, hey, we have our expert we'd like to bring in, and they negotiate how that's going to go, and then I come in. I rarely have the opportunity to do any quantitative work, so I'm not usually taking any sort of samples, but my work is more qualitative and observational and interviews. But we might use that to then request that certain types of sampling or testing be done.
Do you, I heard you mention, Mark, safety committees, and, do you find in your experience, union side, technical guy, that safety committees, while it obviously sounds really nice, do you find that they are indeed the most effective way to sort of root out, and try to solve safety issues? Because I've certainly heard employers sort of speak skeptically about it.
They can be a really positive tool if they're structured right, and you have the right people on the committee and they have support. And there are good examples of excellent safety and health committees. But what it requires is a proper structure, so you have equal voting, and you have all the sort of basics of how you run a good meeting and problem solving. But then you also need to have the members on the committee. And from the labor side, the problem we often saw was the labor members, they only had time off to attend the meetings, so there was no built-in time for them to actually plan or do anything. Prepare, unless they did it on their own time, which many union members would do that. But then there's the issue of needing the support, because the management side typically has their health and safety staff or consultants, but the unions often don't have anyone who's technical on their side. And so one of the problems that I see where I've come in to support a safety and health committee that may be ongoing when I was at SEIU or some other unions is the union members didn't have support, and they would rely upon the technical expertise of the management, say industrial hygienist. Right. Now, no, that doesn't mean that's bad. It could be fine, but I would often see where the management industrial hygienist wasn't really doing the job I would have thought they would have done, because they didn't really see that they were reporting to their management, not to the union. On the other hand, I report, when I come in and help, I'm reporting to the union to the leaders of the union representing their members. So it's just a different perspective. The other perspective we often see different is a lot of times these committees sort of fall into looking at really small issues, or they look at issues that involve, sort of the reverse of the hierarchy of control. So they're looking at protective gear and not engineering controls, because that's cheaper and easier to do. And then the final problem I see that's always disappointing is I'll see the Safety and Health Committee become a health promotion committee, where suddenly the committee focuses on smoking cessation or obesity or some other issue, which is important issues, and unions work on those issues with their members, but it's not occupational safety and health. So it's not really doing the job it should. But when a committee is structured well, supported well, I think committees can really can do marvelous work on both small issues and large.
For sure. No, that's helpful.
I noticed in looking at your bio that during your tenure working with the Washington Committee for Occupational Safety and Health in Seattle, you were dealing with workplace violence way back in the early to mid 90s. Is that right?
Yeah.
And
Yeah.
how is workplace violence from a worker safety perspective changed from then to now? And I'll tell you, I've been involved in a couple really interesting cases dealing with workplace violence. One was in Waco, Texas, where there was a biker shootout. If you remember that,
I do. Yeah.
probably
Yeah.
one of the most interesting cases I've been involved in. And then there was another one I was involved in representing a client at in Cincinnati, where a shooter just was going around shooting up people in a bank. How has that changed in terms of the viewpoint about the need to address this from the 90s where we are today? Because it just seems like, OSHA takes the view that only certain industries or certain places where you may be doing business, you should develop a workplace violence prevention program. But with the more mass shootings and things like that, it seems to me that it's more prevalent these days. And just try to get your take on what was the viewpoint in the 90s and how has that changed to today?
I was in working in Washington State then, as you said, and I remember in the early 90s reading my first scientific article in the public health journals about workplace violence. And I'd say my first reaction was workplace violence is not occupational health. That's law enforcement. Until I read the article, and then I went, oh no, this is occupational health, and the controls are public health controls, just like we do in, with chemical hazards or anything else. So I sort of had this initial skepticism, and then sort of quickly saw how wrong that was. In Washington State at the time, they had passed a late night retail regulation under their state OSHA program, so that did some things to require employers to take efforts to prevent late night retail robberies and shootings. But we were starting to hear then about the problem of workplace violence in both healthcare and then beyond. And I think comparing then to now is we've just seen, we've seen it become that much of a greater issue. It's, one of the major reasons that women die on the job. It's a major reason for injuries in a lot of sectors, like in healthcare. And I think we now know that there's a lot that can be done to try to identify potential hazards and correct them. When I was at SEIU, I used to do a lot of talks at conferences and meetings about workplace violence with healthcare workers, and I remember asking, how many people have had a violent incident in the last year, and there'd be a room full of 100 nurses, and half of them would raise their hand. I would say, how many of you have been threatened, punched, spit on, bitten? And they'd all raise their hand. They go, well, that happens all the time. And it was just heartbreaking to hear the stories of. And I remember one state public sector employee said, we plan for a week a year where we're injured, where we're gonna be out for work, and we don't go on workers' comp. The state has a program; they pay us our full wages, so we won't get too upset about being off for a week, and then we go back to work. And I don't know how those people went back to work to face that level of violence and assault and injury. But I think I think there are many more employers who recognize this problem. In and outside of healthcare, but even within healthcare. There are some really amazing, wonderful programs that are in healthcare that I've seen that are I think they're effective, but they're also very respectful of patients. So that because in healthcare, a lot of the violence comes from patients that might have mental illness, or they might have be under certain under drugs, or there's other reasons. And so the healthcare workers are often faced with I'm trying to take care of a patient, but that patient may be violent. But I still want to do my job to care for the patient. So it becomes this real, in some cases, difficult issue to get. It's easier now, but it was hard to get some healthcare workers to really take this as seriously as it needed to be taken, because they saw it as an obstacle to patient care. I think that's mostly over now, because there's been such a rise in the past 5 years or so of violent incidents in healthcare.
Yeah, it'll be interesting to see if under the new administration whether they make an effort to promulgate a workplace violence prevention program standard in and of itself.
Yeah, there was a standard proposed petition by a number of the unions under the Obama administration, and SEIU was part of that effort. We were part of that effort, and so yeah, I'm hoping that that something like that will happen. We did get a workplace violence regulation. It was pretty comprehensive passed in California, and it was starting to go into effect, and we were hoping to start to see some of the benefits and the prevention of that. But then COVID's hit, so I haven't, not much has happened on that, I don't think, until we get through this pandemic.
One last question, Mark. I know you've been in this field for over 40 years, and recently, last year was OSHA's 50th birthday, if you will. Aside from COVID-19, what key worker safety and health issues do you see that need to be addressed, either by unions or the government or both, in the next 10 years?
Wow. Yeah, that's an enormous question. I mean, I think that there are certainly issues like heat stress that I think that are out there and going to become more significant problems in the future. As an industrial hygienist, the problem with the OSHA PELs and how outdated those are, and OSHA's seeming inability to kind of update those in any way that's going to be effective is something that needs to be addressed. I know Dr. Michaels in the last administration in the Obama administration, pushed hard for health and safety program standard so that, OSHA would have to less rely on specific standards, but rely on employers overall looking at the issues, identifying hazards, and then coming up with ways to control those. Those are all issues I think that'll be helpful over the next 10 years to try to move safety and health forward. And there's probably things we've not even thought about yet that we're going to run into.
Right. Exactly. Well, hey, Mark, we really appreciate you being on our show. It's been an honor and a privilege, and we've learned a lot, so thank you.
Thank you so much.
And stay tuned for the next episode of the Workplace Safety Review Podcast.